Okay, our anchor leg here is a good friend, Dr. Trip Gulick, who is the Chief of Infectious Diseases at the Weill Cornell Medical Center and New York Presbyterian Hospital. Trip has been a pioneer in antiretroviral therapy and especially the evaluation of new drugs as they emerged from the mid-1990s onward. And so I can't think of anybody really better to talk about the future of antiretroviral therapy, especially with regard to long-acting regimens, those that exist, but especially those that are emerging. And look forward to hearing your talk, Trip. Unmute.
Thank you, Mike. Did that take care of it?
Yep, took care of it.
Great. So thanks for having me to talk about long-acting antiretrovirals as well as emerging therapies. I don't have any financial relationships to disclose. Our learning objectives today are to describe investigational long-acting agents for both HIV treatment and prevention, and to list investigational drug formulations for the same, HIV treatment and prevention. So let's jump in. Let's first talk about investigational long-acting agents in the pipeline. We'll start class by class. Nucleoside reverse transcriptase translocation inhibitors, NRTTIs, an investigational ART class. And the compound that's been around a while, but still investigational, is islatravir. It's an adenosine analog, works as a DNA chain terminator, but has a novel mechanism of action. It inhibits reverse transcriptase, but by preventing translocation. So an NRTTI is a nucleoside reverse transcriptase translocation inhibitor. It has a long half-life and few drug-drug interactions are anticipated. It's quite potent in the test tube and has broad coverage, not just against HIV-1, but HIV-2 and multi-drug resistant strains. Part of the excitement about this compound are its low dose and parenteral formulations. In an early phase 1 study published and shown for you here, a single dose at time 0 led to up to 2 log reductions by day 10, showing both potency and that it's a long-acting agent. This drug was, investigational agent, was combined in treatment-naive studies with doravirine, the NNRTI, and those results have been published. That supported phase 3 results that were done in both treatment-naive and in switch populations, and you can see 3 phase 3 studies that are referenced for you there. But what I'd like to focus on are the long-acting aspects. A related compound to keep in mind is GS1614. This is a prodrug of islatravir that can be injected every 3 months. What was the problem with these early studies with islatravir was a unique toxicity, and that is lymphocyte toxicity. And that's shown for you here in the graphs. In the first one, islatravir is shown in green. What we're looking at here is the lymphocyte count. And you can see that it went down in various study arms compared with not much change in the comparator. Second shows the same thing. In blue are increasing doses of islatravir associated with declines in lymphocyte counts without a change in the comparator regimen. And similarly in the third graph. It does look to be dose ranging, and what you see here is 2 doses of islatravir, a lower dose and a higher dose, corresponding with changes in lymphocyte count compared with the comparator arm, which showed no change. So this became a focus of concern early on, and the FDA actually put clinical hold on all studies with oral, injectable, and implantable islatravir. They did significant work to try to elucidate what was the source of this toxicity. The first thing they noted was that no other blood cell lines were affected. So other white cells, red blood cells, platelets did not change. There were no signals of lymphocyte toxicity in early animal or phase 1-2 human studies. The manufacturer determined the likely mechanism is islatravir triphosphate levels that inhibit DNA polymerase A and lead to apoptosis and cell death. This is not a mitochondrial toxicity. The toxicity is dose dependent, it's reversible, and wasn't associated with increased infections. And so modeling by the manufacturer suggested that a lower dose of islatravir given either daily or weekly was the optimal way to dose this drug and was not associated with lymphocyte toxicity. This supported moving forward with further studies, and in one of the first regimens of weekly oral therapy is using islatravir in combination with the capsid inhibitor lenacapavir. A phase 2 randomized open-label controlled study was presented at CROI last year. They enrolled people with HIV on a standard triple drug bictegravir-based regimen with virologic suppression for at least 24 weeks and no history of virologic failure. They had CD4s greater than 350, a lymphocyte greater than 900, and no active or occult hepatitis B. And this was a phase 2 study of just over 100 people. They were randomized to continue their bictegravir regimen or switch to islatravir, and note the dose 2 milligrams a week, with lenacapavir 300 milligrams a week. And this was oral dosing, 2 pills. And how'd they do? So 24-week results were presented at CROI. And as you can see, 94% of all patients on the study maintained suppression of their viral load to less than 50 copies. CD4 cell counts and absolute lymphocyte counts were not different with the two regimens. They concluded that this could be the first oral weekly regimen and that it appeared to be both efficacious and well tolerated. And at ID Week, we heard recently the 48-week updated results, and you can see sustained virologic suppression rates with the weekly regimen at 94%. So looking forward to phase 3 studies of this novel 2-drug combination for weekly oral therapy. There's another NRTTI in the pipeline, it's not named yet, MK8527. And at CROI, we saw early studies in people without HIV that demonstrated a prolonged half-life of the drug, 200 to 300 hours. And that would support weekly or even monthly oral dosing of this compound. Also at CROI were the first in-human studies, 2 phase 1 oral single-dose studies in people with HIV and no prior ART. And you can see 31 people enrolled and given single doses of this 8527 compound at the doses listed for you there. What were the results? Virologic suppression occurred roughly the same at all 4 doses and showed the potency 7 days after administration, once again demonstrating its longer half-life. Generally well tolerated, and they concluded that single doses as low as 0.5 milligrams a day achieved greater than 1 log decreases up to a week later, and noted that this compound has potential for both treatment and prevention of HIV. In fact, at the R4P conference in Peru last fall, weekly oral PrEP with 8527 protected rhesus macaques from rectal SHIV challenges, showing the potential for this compound as a weekly oral PrEP dose. And in fact, right now, phase 2 monthly oral PrEP study is enrolling with 8527. This would be the first once-a-month oral PrEP pill. What's going on in NNRTIs? Well, ulonarivirine, used to be called MK8507, is being developed and has potential as a long-acting agent. It's potent in the test tube and, interestingly, active in vitro against common NNRTI-resistant variants. But the real interest is its long half-life, 70 hours, and once again supporting once-weekly oral dosing. It has fewer CNS side effects in early studies than other NNRTIs. A phase 1 study that enrolled only 18 people looked at people with HIV who were treatment naive, had viral loads at least 10,000, CD4s over 200, no non-nuc mutations, and no viral hepatitis. And they tested 3 single doses of ulonivirine. The results showed it was generally well tolerated. One patient did develop an NNRTI mutation, which was uncommon. And as you can see here, all 3 doses led to prompt virologic suppression up to 1.5 logs below baseline at the higher 2 doses tested. The conclusion was this is another compound that could support weekly combination therapy studies. Drug resistance profile has also been elucidated with this NNRTI. You can see that the signature mutation is V106A. Yes, if that sounds familiar, that's the signature mutation for doravirine. And you can see some other common mutations, 103, 181, 190 in the reverse transcriptase led to some changes in susceptibility to ulonivirine. So in all, similar to doravirine in its resistance profile. A phase 2 study was planned, and that was ulonivirine, easy for me to say, at 1 of 3 doses with islatravir at the higher dose oral weekly. And this was one of the studies that I showed you previously that showed decreases in lymphocytes and consequently CD4 cell counts. This was placed on hold by the FDA, but that has now been released, and a future study will use a lower daily dose of islatravir with ULO, that's easier to say, weekly. So another once weekly oral regimen being studied. What's new with integrase inhibitors? Well, there's a new long-acting integrase inhibitor called GS-1720. Once again, potent in the test tube. After 16 passages in vitro, no resistance was seen, and thought in the test tube to have 7-fold higher potency than bictegravir in clinical PBMC isolates. A phase 1 study was presented at the IAS meeting this past summer of GS-1720 at the doses that you see there in 8 patients without HIV. So this was a pharmacokinetic study. It showed that it had a long half-life of over 9 days, nonlinear pharmacokinetics, and was generally well tolerated. At the CROI meeting earlier in 24, we heard a phase 1b study, which was an oral open label multi-cohort study that enrolled people with HIV who were either treatment naive or off of antivirals for 12 weeks. And you could see a small pilot study, only 7 people. They dosed 1720 on days 1 and 2, and then followed the people for 10 days to look at virologic responses. And what did they see? Well, first of all, the median half-life was confirmed at being 9 days, which would allow, once again, weekly oral dosing. And this was a potent compound. The viral load decrease was 2.4 logs at day 11, and no emergent INSTI resistance was detected. Generally well tolerated in this small study, and they concluded that it should move forward. There are a number of other injectable integrase inhibitors in the pipeline at earlier stages, and you can see the compounds here, 6212 and 1212, and 3242 can be dosed parenterally either every 3 months or every 6 months. So a boatload of long-acting integrase inhibitors on its way. Another interesting compound in the pipeline is a so-called 3rd generation integrase inhibitor. And we heard about the early in vitro data at the IAS meeting this summer. Antiviral activity of this compound, known as VH184, was determined against lab and clinical isolates, and I'll show you those data. It is potent against the integrase enzyme and potent against HIV as well. In vitro passage up to 112 days showed no mutations emerging in the presence, HIV in the presence of VH184. But here's the interesting in vitro data. It's a complicated slide, but let me walk you through it. What we're looking at across the bottom are common integrase inhibitor mutations. And you can see towards the right, we have double and even triple and quadruple mutations. And then the different bars represent different compounds. These are all in vitro test tube data. In the front row is rilpivirine. Well, that's an NNRTI. You wouldn't expect any resistance with integrase-associated mutations because it's a different mechanism. And in fact, it serves as a good control here. Let's go to the back row. That's L-vitegravir, as we know, an integrase with a lower barrier to resistance. And you can see with some of the single mutations, high level resistance conferred. And then when you get to double, triple, and quadruple, complete resistance to L-vitegravir. In orange is cabotegravir, a better profile, but once again, when you get to the multiple mutations, you see high level resistance. In purple is dolutegravir, very similar profile. Once again, triple or quadruple mutations confer resistance. The new compound, VH184, is in navy blue. And what you see here is very little resistance, including to multiple mutations. And so that makes it a so-called third generation integrase inhibitor. Well, those are test tube data. We also heard the first in human data presented at the IAS meeting. And this looked at various doses, and it looked at drug-drug interaction studies, and it looked at food effect, either fasted or fed. And these were done in people without HIV. So 84 participants, it was placebo-controlled. And what did they conclude from their data? First of all, in terms of pharmacokinetics, dose proportional increased concentrations up to 300 milligrams. So you can see the first 4 cohorts, and then it levels off. Minimal impact on midazolam, and that is a marker for CYP3A4 interactions. And there was a moderate positive food effect, and all in all, safe and well tolerated. So these data together will support going into phase 2 in people with HIV, and those studies are planned. What's new with capsid inhibitors? Well, probably the big news of the year of 2024 is lenacapavir for HIV prevention. And these are the PURPOSE studies. PURPOSE 1 and 2 both have been recently published. PURPOSE 3, 4, and 5 are in progress. So PURPOSE 1 was studying twice yearly lenacapavir subcutaneous abdominal injections versus the standard of care daily oral tenofovir as PrEP, should be tenofovir and FTC, as PrEP in cisgender women. This was a randomized double-blind phase 3 study in South Africa and Uganda, and they specifically enrolled cisgender women aged 16 to 25 who had risk of HIV, and importantly, had an unknown HIV status and had not been tested for HIV for at least 3 months prior to coming into the study. They had adequate renal function, and this was a big study, over 5,300 people. They were screened initially, and women who were found positive because they hadn't been tested or had unknown HIV status led to an estimate of what the underlying prevalence in this population was. And that was used as a comparator arm. But the women who were negative were randomized to one of 3 options. The first group got lenacapavir injections every 6 months. The second group got oral FTC TAF once daily. The third group, this was the control arm, FTC TDF orally once daily. And as you can see, it was placebo-controlled. Everyone got pills and everyone got injections. Bottom line, the study was stopped early by the Data Safety Monitoring Board because of a significant difference, as shown for you here. What we're looking at is the incidence of HIV per 100 person years. And you'll see that lenacapavir had 0 infections over the course in over 2,100 people. Note the comparator arm on the left. This was the background incidence in this population. You can see pretty high, 2.4% per year developing HIV, and that was estimated based on the screening period. And then, somewhat surprisingly, TAF FTC, TDF FTC really not significantly different from the background incidence. And certainly lenacapavir was better. Injection site reactions were common, but led to discontinuation in very few patients. And all of these results are explained by adherence. So adherence to lenacapavir injections, which of course was done at study visits, was 93%. But the number of women taking more than 2 doses per week of the oral regimens was less than 20%. So that explains the differing results. Next came Purpose 2. So Purpose 1 in young women, Purpose 2 in men who have sex with men and transgender women. And this was enrolled in the countries that you see here. So in the Americas, Africa, and Asia. These results were presented by Colleen Kelly at the R4P meeting earlier this year, and then just recently, last week, published in the New England Journal. They enrolled over 3,200 MSM and transgender women. A third were under 25, the age of 25, and over 60 were Latino. They were randomized to get either the lenacapavir subcutaneous injections every 6 months or 1 pill once a day, TDF-FTC, the standard of care. Once again, the DSMB recommended stopping the study early due to a significant difference. The primary endpoint, once again, was incident HIV, and they had a follow-up of about 39 weeks. There were 2 cases of seroconversion out of 1,900 people in the lenacapavir arm, compared with 9 out of 967 in the oral regimen. And once again, the background incidence was measured in people who screened out of the study. That translates to a decrease in HIV, 96% with lenacapavir versus background, and decrease of 89% versus TDF-FTC. All these results are being submitted to the FDA for their review. Something else in the pipeline is GS-4182. This is an oral prodrug of lenacapavir that converts to lenacapavir in the gut. It had favorable preclinical evaluation and has gone into human study, which we heard the first randomized blinded placebo-controlled study at the IAS meeting this year. They used single and multiple doses of 4182 in people without HIV. Again, that was for pharmacokinetic results. And what did they see? GS-4182 is broken down to lenacapavir, and they achieved similar concentrations to standard doses of lenacapavir. The compound was safe and well tolerated, and they concluded that this is favorable pharmacokinetics and could move forward as yet another oral weekly drug. And they've combined that with the integrase inhibitor I reviewed earlier in a 2-pill once a week regimen given weekly. What about BNAbs, broadly neutralizing antibodies? Well, there are a number of them. This is GP120 sitting on the surface of a CD4 cell, and the different colors represent different binding sites of various monoclonal antibodies. Here's the CD4 binding site, and you can see the box is full of monoclonal antibodies. Other portions of GP120 are targeted with other groups of monoclonal antibodies, as you can see here. Over 17 broadly neutralizing antibodies have been evaluated for safety and pharmacokinetics in humans, and clinical trials have generally demonstrated both their safety and their antiviral activity. But they're not just antiretroviral agents. They have a vaccinal effect due to their Fc receptor. That is, it enhances host immunity. There have been strategies to improve the potency of BNAbs, their breadth against viral strains, improve their half-life, and improve their delivery. And there are now more potent, broader, and multi-specific antibodies with longer half-lives that can be dosed up to every 6 months, and the prospect for subcutaneous dosing as opposed to intravenous infusions. There are also combination strategies, phase 1 and 2 studies, that combine BNAbs with each other or with long-acting antiretrovirals like cabotegravir or lenacapavir. One of the most remarkable studies is this pilot study published by Joe Eron in Lancet HIV, Lenacapavir with 2 BNABs. And this was a pilot. So it enrolled 20 people who had viral susceptibility to 2 monoclonal antibodies, abbreviated TAB and ZAB. Their CD4 at entry was above 500, and they were never less than 350. And all received one of 2 options. Everybody got lenacapavir and TAB, the monoclonal, and then 2 different doses of ZAB were tested. People got oral for a day or 2, and then a single intravenous infusion, and were followed for 6 months. At the end of week 26, so about 6 months, 90% in all the groups turned out to have suppressed viral loads. So 6 months later, 90% or 18 out of 20 had virologic suppression. And so they concluded that this had the potential to be the first 6-month ART regimen. Part 2 of the study had an identical design, but the only difference was people didn't have to be susceptible to TAB and ZAB. They only needed to be susceptible to 1 out of the 2. And so when they did the same thing, 8 of 10 maintained virologic suppression, but they did see 2 virologic failures. And so that strategy was really set aside for the future. So further studies with this combination will look at people who are susceptible to both monoclonal antibodies. Other BNAB studies have been done. People have used triple combinations that showed virologic suppression, or 1 antibody with 3 binding sites. And these are investigational approaches. Okay, lastly, what about other long-acting formulations of the compounds and drugs we use today? Well, one exciting one is combining TLD. That regimen is tenofovir, 3-TC, and dolutegravir, the most common regimen used worldwide. About 80% of people are taking 1 pill once a day worldwide who are on antivirals. These drugs have disparate physical chemical properties, but with a new combination nanoparticle technology, they were able to stabilize using lipids a formulation that was suitable for subcutaneous injection. And this is non-human primate data, but what you see is that the solid lines with this new formulation exceed the target line shown in the dotted line. And what they concluded here is that a 4-week subcutaneous dosing formulation could be possible with this commonly used regimen. Cabotegravir we're all quite familiar with, and as everyone knows, it's an every 2-month formulation given intramuscularly, but there's a new 400 milligram per mil formulation that is being studied, and we saw some of the first results with that at CROI last year, that the cabotegravir 400 had safety and pharmacokinetics that supported every 4-month dosing. And further clinical studies are in progress. There is also a cabotegravir prodrug that has been studied in animals. And as you can see, the doses, once again, in the different colors, exceed the target doses in both rats and with the higher doses in dogs. And this would be compatible with every 6-month or even every year dosing of cabotegravir. INSTIs are also being looked at with long-acting formulations. Bictegravir has a nanoparticle injectable formulation, and as you can see, it has prolonged therapeutic levels up to 6 months. And similarly with dolutegravir, we heard these results at CROI. And then there are Bic prodrugs that are also being used, and you can see that they achieve good levels. And unlike other long-acting antiretrovirals, once you stop the dosing, they fall off rather quickly. So a low pharmacokinetic tail. And so we look forward to the future with these novel formulations. What about implants? Well, this is a study to show you not everything new is going to be good. This was a TAF implant that was studied in South African women. And the bottom line was that they had insertion site reactions, hyperpigmentation, induration, and scarring. And so many women had these for prolonged periods of time, up to a year, and was really not popular. So over 35% withdrew from the study early, and pharmacokinetic targets were not reached in most patients. So this TAF implant is back to the drawing board, and other implants are being studied. And then lastly, patches would be quite popular. And you can see a picture of a cabotegravir patch that was used in humans. Once again, the target level is the red horizontal lines. And you can see that these patches did achieve therapeutic targets. However, not ready for prime time yet, and further study going on. And by the way, although they look kind of treacherous here, they don't actually engage the nerves, so they are not painful to wear. So last slide, what are our potential future options with long-acting antiretrovirals? Well, as I stressed, once weekly oral treatment, there are many combinations that are under study right now, and that may be a reality fairly soon. Who would benefit from once weekly treatment? Well, it would be a particular kind of person, but again, choices are great, and so some people may elect to do this. Once monthly oral PrEP also may be quite popular, and that's under study right now too. Injectables every 3 to 12 months are being studied with the new formulations of CAB, other integrase inhibitors, lenacapavir, and monoclonal antibodies. Implants are at an earlier stage of development. Some of these are removable, refillable, or biodegradable, and they are in early studies. And as I mentioned, patches with both cabotegravir and TAF are under study. As well, we have newer formulations, prodrugs, and mechanisms of action, including the NRTTIs and the broadly neutralizing antibodies. So the future looks bright for long-acting antiretrovirals, both for treatment and prevention, and choice is going to be really key to match people with the kind of long-acting treatment that they may want to take. And with that, I'll just acknowledge people that helped and supported a lot of this research, and thanks for your attention.
Well, thanks very much, Trip. Comprehensive, pretty exciting, really, when you think about all the new approaches, and obviously the trend is for longer acting medications. A couple questions here. One is just a straightforward question about TAF FTC for cisgendered women for PrEP. Are there any study updates for that? You mentioned a control group here and there, but you think that's going to be explored further?
Yeah, the first good data we have on that is actually from the lenacapavir study, because it was one of the 3 regimens that was tested. Remember, the problem with that study in the oral agents was that the women really didn't take the drugs regularly. So we still have incomplete data on TAF FTC for women as PrEP. There are some emerging pharmacokinetic data to suggest that it probably works, but we don't have the complete data.
The other one is on when the implants were used, where did they place them? Do you remember? Was it in the arm or thigh?
It was in the arm.
Mhm.
It was on the arm, similar to the contraceptive implants that are used
Exactly.
quite commonly in Africa. So women were used to these, but it wasn't foreseen the kind of local reactions that they would have that really made them quite unpopular and not well tolerated.
Trip, if I can just interject one, why do they put them in the arm? Is that just convention, or is there some advantage to that over some other location?
That's a great question, Henry, which I do not know the answer to. I would guess that it's because of ease of putting them in, that arm is just more acceptable and more accessible than other places.
Yeah.
It's typically the upper arm, by the way, not the lower arm.
You know, one thing I'm hearing, Trip, anecdotally, that doesn't seem to be coming out on the purpose reports is these relatively anecdotal, but seemingly very real reactions to lenacapavir injections among some folks. It seems to be a profile of relatively thin folks who get the injection and then it hurts and people actually scream, they say, followed sometimes by a large golf ball size reaction at the injection site. Interestingly, despite that, patients tend to come back for repeat injection 6 months later. So it goes away and then they undergo it again. Are you hearing much about that type of reaction? It's not common, but to lenacapavir?
Yeah, so two different things. The golf ball size is actually how that drug works. So you're injecting a 6-month supply of lenacapavir, essentially. That's the depot for the drug. And over time, that will lessen and lessen as the drug is eluted into the circulation. So you were right to point out that that's more noticeable in thinner people. And it makes perfect sense. If you have some abdominal fat to hide it in, it's not going to be much of a problem. But yeah, we can reassure our patients and people on trials, that's what's supposed to happen. You're supposed to have that. The pain thing was talked about a lot earlier, and they did not see that in the Purpose 1 study done in Africa. So that's kind of interesting. Whether that's too is related to the amount of abdominal fat people have, I don't think is quite clear. But you were right to point out that the discontinuation rates on the lenacapavir studies really low.
Yeah. So what do you think the future is for BNABs? I mean, my thought is that it's kind of interesting. It's logical, makes sense. But in the setting where there's so many other options for long-acting medicines, the BNABs I know are pretty expensive to make. I'm not sure they're going to be commercially viable. What are your thoughts?
Yeah, I think it's a great question. Of course, we don't know how much any of these things would be because they're all investigational, but you're right to predict that BNABs will probably be more expensive. And we know that from other diseases that BNABs for cancer or for COVID are expensive drugs. I was really interested and featured Joe Eron's study looking at a single infusion of 2 BNABs and lenacapavir protected, maintained virologic suppression for 6 months. So that would really be revolutionary if we had an all injectable regimen that could really hold people for 6 months. I think you're right to point out that what about low and middle income countries? Could they ever really use monoclonal antibodies? We used to say that about integrase inhibitors, and of course the price came down and they were made generically. So there's hope there, but I think initially it's going to be in more resource-rich countries, probably.
Yeah, Trip, you mentioned injectables, but if you had to predict what would be optimal in the future, is it a long-acting oral? Is there some advantage to giving an injectable since it seems like we're going to have lots of choices in the future? And do you see, again, a biologic being part of that?
So a couple questions there, Henry. I think people like choices. And so it's interesting when you start talking to people about PrEP right now. Some people are perfectly happy with 1 pill once a day. I'm guessing some wouldn't mind 1 pill once a week or once a month. And others like injections more because they don't have to take pills. I had a young guy say to me, only old people take pills. And
It's true.
I acknowledge that, but we've learned from contraception and other fields that people want choices, and particularly for prevention, people are going to want to pick the thing that fits in best with their own lifestyle. How do the monoclonals, how will they play out in terms of prevention? Well, we have relatively limited experience so far, the big AMP studies that were done in Africa. If you were sensitive, that HIV was sensitive to the antibody, that was a good thing and you avoided infection. Didn't work, makes perfect sense if you had a resistant virus. So more to come on that.
Right. So unfortunately, we're out of time. There are a couple more questions in the Q&A. Trip, I don't know if you have time to just type an answer into those if you could. But that was a very comprehensive and really fascinating review of where we are, which is kind of exciting and good to go. So we're going to need to close now.